So more than just. Put it down. I got it. Great. Thanks so much, Liz, for your thoughts about successful aging and for all the work that you do on a daily basis. I would like to invite Mary Krugman to the podium to introduce our last keynote speaker. Dr. Krugman is the Director of Nursing Innovation and Outcomes at the University of Colorado Hospital. 2 years ago, she received the Nightingale Award for Excellence from the Colorado Nurses Foundation for her outstanding ability to motivate others to work toward a common goal. Mary?
It is really my honor and pleasure to be the one to introduce Di Smalley. There's probably no one better qualified than Diane Smalley to talk with us about creating volume and quality in healthcare. Di was responsible for taking a hospital in Nebraska that was in receivership to a healthy institution, the first hospital ever to make that transition. She did it by building quality and recruiting the right group of healthcare providers. Ms. Smalley knew that she wanted to be a nurse from the age of 3. And when she was starting her nursing program, she knew right away she wanted to be in the leadership track, and her work has proven that over the years. She has extensive knowledge of for-profit and not-for-profit hospitals and healthcare sectors, as well as experiences as a nurse executive, CEO, and system executive. All of this has prepared her well for her current role. Di is a regional president of Mercy Health in Oklahoma. What's really significant too, and one of the reasons that she's been asked to be a speaker today, is that she is one of the first, she's really the second nurse since 1936 to be the chairman of the American College of Healthcare Executives and a fellow in that organization. This is an amazingly powerful organization internationally with more than 40,000 healthcare executives who lead hospitals, healthcare systems, and other healthcare organizations. And I have a recent addition to this. She's the 4th female chair in 125 years. And just this, I think she's the first female nurse who's been in that role. So this is a premier society for healthcare executives dedicated to improving healthcare delivery. So this is an amazing leadership role model for all of us. Her leadership role extends into the community as well. Di has served on many community boards related to healthcare. She currently serves on the board of directors for the Oklahoma State Chamber of Commerce and is also on the board of United Way of Greater Oklahoma City. Ms. Smalley received her master's degree in public health from the University of Minnesota. Her positions in leadership and healthcare have led to improvements in access for care and improved quality for many of our citizens. And she will speak to us today on quality and value added, the whole value added issue in healthcare. So we're very happy to have her. Please join me in giving a warm welcome to Diane Smalley. Thank you.
You know, one of the drawbacks of that successful aging is your introduction keeps getting longer and longer and longer. I really am honored to be standing before you today. In fact, when they called and asked me if I would do this, I have to tell you I was a bit intimidated. I speak to healthcare executives all over the country and all over the world. I just completed my 30th state 2 days ago. But when I speak in front of nurses, it's intimidating to me because I have to tell you that a lot of nurses think I went over to the dark side a long time ago. My own sister is a nurse, and she's a supervisor in a hospital in Omaha, and of course she poo-poos the fact that I'm actually a nurse because, as she says, I haven't touched a patient in 40 years. So I always say to her, and I say to the audiences that I talk to, that, you know, we all have to find what we're really good at and what we have a passion and love for doing, and for me, that's healthcare leadership. So I always say I can contribute more to nursing in this role than I could at the bedside, and I appreciate that. So I was asked to come today and talk about volume and quality, and those two are not one versus the other. In fact, I believe for the future it has to be both, volume and quality together, and I'm going to talk to you about that. Just a few months ago, I had the very great privilege of speaking to the International Hospital Federation meeting in Oslo, Norway. And I was speaking at that time on how to have a benchmark program and have a succession planning role for healthcare leadership. But in the 5 days that I was there, I got to sit through a lot of the other presentations from across the world. And you know what? My eyes were opened in doing that. I spent 40 years of my career in healthcare in the United States, and I've been always very proud of what we do in terms of quality and the outcomes that we have. But here's the shocker. Here's what I found out. That's not how we're seen around the world. I will tell you that in every single presentation that I heard, the speaker managed to work it into their presentation somehow, the fact that the United States had high costs and the outcomes were not as good as other countries. I saw the same graph, I can't tell you how many times. It's a quadrant graph, and it would show us up here and then other countries around the world. So the reality is that the rest of the world does not see the United States healthcare as the be-all and end-all of what it should be. To the contrary, they see us as an overpriced system with questionable outcomes. And that was a shock to me. As Andrew Garman points out in his book, The Future of Healthcare, Global Trends Worth Watching, there are both cross-country and within-country evidence that more spending does not necessarily transfer into better outcomes. Economists refer to this phenomenon as the flat of the curve medicine. You know, even before attending this international meeting, I obviously thought that there should be a way that we could do more with less. You know, you have to understand, I've seen it on both sides. I'm a nurse. I have been a director of nursing. I have also been the CEO of a hospital, and I'm regional president over 17 hospitals in Oklahoma. And so I see both sides of this, and I can tell you that I spend my life now speaking to healthcare executives across the world, and I will tell you that there isn't one that I have met yet that doesn't want the same thing that you in this room want. We want high-quality care, but we know that the dollars are not going to be there for us to produce it in the same way that we have in the past. And so we have to understand that as well. So, you know, other industries have made this transition. We're all aware of that. There's many examples out there. Other countries have made this transition. And quite frankly, we cannot continue to spend the kind of money we do on healthcare in the United States. Right now, we have a high percentage of our gross national product that is spent on healthcare. That cannot continue to increase. There simply isn't that kind of money to spend. Certainly, what's going on in this city in the last few weeks should convince us of that. So I want to ask, as I focus my remarks today, that we look at not the paradigm shift from volume to quality, but the paradigm shift to volume and quality, because that's what we're going to be facing. You know, Kenneth Galbraith once said that faced with a choice between changing one's mind and proving that there is no need to do so, almost everybody gets busy on the proof. I'm asking that you work with me today and not jump immediately to finding the proof that these can't coexist. For the next few minutes, what I'm asking is come live in the learning zone with me and out of the comfort zone. I heard a statistic not long ago that today the average primary care physician has 3,000 active patients within their practice. If we continue to produce practitioners at the rate we do today, by the year 2020, yes, that's 7 years from now, the average practitioner will have to have 10,000 active patients in their practice. Now, I employ a lot of physicians in Oklahoma, and I'm not sure that I have any that can tomorrow go from having 3,000 active patients to 10,000 and be happy with that fact. So I really believe we really are at a crossroads. I believe we have no choice but to reform our healthcare system. I'm not here to make a political statement to you about the Affordable Care Act. I am the chairman of the American College of Healthcare Executives. We're very careful in not being an advocacy organization. What we are is an education organization. We want to make sure that our members know all the facts and draw their own conclusions. And we're very much into diversity in the American College of Healthcare Executives. And by that I mean not only diversity in gender or ethnicity or whatever, diversity of opinion. I love the idea, in fact I quote it frequently, that if you and I are having a conversation, we have the same thing to say, one of us is unnecessary. So it's very important that there is a rich and diverse conversation about where we need to be. But reform, I believe, is unquestionable. As I mentioned, we're not producing caregivers at a rate that keeps up with patient demand. That's one thing that I know. So instead of talking politically to you, I'm going to tell you what I know. I know that we're not producing the workforce we need to keep up with the patient demand. The second thing I know is that the patient demand will increase because us baby boomers, successfully aging or not, are increasing. And as we increase, the chronic diseases that have to be cared for increase as well. And finally, there's not going to be buckets of money falling down on healthcare. And so I don't believe we have any choice but to reform what we do. My favorite definition of reform is this: making things better. So if you accept that definition and you accept the three facts that I just told you, not a workforce to keep up with our current system, increasing patient population, and no additional money being sent our way, then it should be obviously apparent that reform is going to be necessary. So somehow as a country, we must come to terms with the need to provide excellent care at the same time we cut costs. As I mentioned earlier, other countries have done this. We remain the strongest nation in the world. Surely we can do it as well. Many years ago, I was honored to be part of a think tank that actually came up with the concepts of performance improvement for healthcare. Don Berwick, Paul Batalden, Chip Caldwell, and a few others of us spent a few weeks out in the woods of Atlanta at a retreat with the then CEO of HCA, Tom Frist, developing those concepts from the Deming methodology. And one of the lessons from that experience in many years subsequent that I've applied it is that those that are closest to the process are in the best position to make changes to it. I know absolutely that this is true. I'm standing here today looking at a room full of folks that are closest to the nursing process on many levels: teaching, research, management, and practice. No one is in a better position to make changes to the nursing process than those that are in this room. And so for that reason, I think it's your mandate to do that. So let's talk a minute about quality. Quint Studer defines excellence as the point at which employees feel valued, physicians feel their patients are getting great care, and patients feel the service and quality they receive are extraordinary. So let's start with the proposition of employees feeling valued. My first nursing job was in the critical care unit of my hometown hospital. I was working on my bachelor's degree at the time, and I worked evenings in ICU. And there was a particular process that we did in that ICU unit that I knew there was a better and faster and more efficient way to do it, because I'd been taught a different way to do it in nurses training. So one day I got up the nerve and I went to the head nurse and I said, I know a better way to make this, to do this process. And she looked at me and she said, what's wrong with the way we do it? I wrote that procedure. And so of course I immediately said, it's wonderful, I love it, I'll follow it, thank you very much. So what did that lesson teach me? It taught me to put my brain at the door, check my brain at the door, follow orders, and be afraid of making suggestions. In other words, what that experience did was it drove in fear and stifled creativity. How many of you have had similar experiences? A show of hands, that's right. What happens to any organization when we ask our coworkers to leave their brains at the door and make them fearful of suggesting improvements is that we stagnate, and the employees do not feel valued. By these actions, we're not allowing those that are closest to the process to have input into improving that process. Henry Evans points out in his book, Winning with Accountability, that making employees accountable for and in fact invested in the performance of their work is the secret language within your organization that can create or prevent success. I believe it's every manager's responsibility to drive out fear. No coworker should be afraid to voice an opinion, to offer a suggestion, or to take the lead in making change. Change should be constant and welcome, and even when things are going well, actually especially when things are going well. Years ago when I was CEO of a hospital, I had an opportunity to experiment with a bit of that philosophy. What I did was eliminated performance appraisals. I said that all employees, we knew that you had a job description and you could do that job description and that's what you were expected to do. And if you weren't doing it, then we certainly had a corrective action process and the manager should instigate that as necessary. Instead, what I asked every employee in the hospital to do was come up with one suggestion for improving their work and the care that we gave patients on an annual basis. And I asked the managers to spend the time that they would normally spend giving an appraisal to talking with that employee about what their suggestion was. And then the manager was charged with either giving the employee the responsibility to go out and make that happen, assigning an interdepartment team that could work on it or a cross-department team that could work on it. No idea was left without being tried. Every coworker had the confidence that if they made a suggestion, we would at least try it and see if it worked. And then what we said is that we require you to do that on an annual basis, but if you want to do it more frequently, we will support you in that effort. You know, it was interesting what came out of that. I'm not going to give you many ideas, but I'll give you a couple. The receptionist in the X-ray department said, remember in those days we had X-ray film. We keep our X-ray film across the department. And I watched the technicians walk back and forth all day long to get old X-rays. Why don't we move the X-ray film where they work? Why not? Another suggestion was from a housekeeper. He said, I don't know if you understand how much time it takes me to tie a knot in plastic bags that I put on garbage cans. But I do that in every single patient room and in every office that I go into. If we would just use this little clippy thing, I could do it a lot faster. Simple. Every one of those things created more efficiency for our hospital. But more important than that, I think it created a sense of investment on the part of the coworkers' point, to say nothing of it helped drive out fear of them making suggestions in the organization. When Mary introduced me, she said I took a hospital from receivership, out of receivership. This was the hospital. All of this resulted in 5 times improvement to the bottom line. Was this because of the actual improvements or simply because the coworkers were invested in their work? I'll never know for sure, but it's a lesson that I've never forgotten. So back to Studer. Once employees feel valued, Studer says the physicians must feel that their patients are getting great care. I spend a lot of time with physicians. I have yet to find one who isn't more concerned with his patients than with himself. Quite frankly, I have yet to meet a nurse who doesn't have the same philosophy. So why is it that doctors suspect their patients are not getting great care? I think the warning signals they see are when they get post-procedure complications or patient complaints or frequent unexpected shifts in patient condition. All of this leads to mistrust among the team. As a leader, I often tell my team that I can support them no matter what the issue, as long as I'm not surprised. I think we need to see the physician as the leader of the patient's care team and avoid surprising him or her as well. Nurses tend to call doctors when patients are in crisis. My contention is that nurses would be better off contacting doctors at the slightest anticipation of a change in condition and not wait for the crisis. Nurses today have access to more than the phone. There are venues such as email and text messages, and I've found that doctors appreciate this less disruptive form of communication to keep them appraised of their patients' conditions. Just as I do as a leader, physicians will also support those that he perceives to be on his team. He can't support those that are working in isolation from him. So that's the first two. Finally, Studer says that if employees feel valued and physicians feel their patients are getting great care, then the third element of excellence is for patients to feel the service and quality they receive are extraordinary. I can't tell you the number of times I've heard nurses say things like, "I'd love to give back rubs, but I'm short-staffed." Or, "I can't spend all day chatting with Mrs. Brown, I have other patients." Both of these statements are true. Nurses have many demands on their time and are frequently short-staffed. This leads me back to what I said earlier. Just as primary care physicians cannot handle 10,000 active patients as opposed to the 3,000 in their practice today without reforming the way they practice, nurses cannot deliver extraordinary care without reforming theirs. Sometimes we can be our own worst enemy. Many years ago, I was serving as a head nurse of a med-surg floor, and the chief nursing officer was working on her doctorate degree. She had did some research and found out that roughly half the population prefers to take their bath or shower in the evening, and half the population prefers to take their bath or shower in the morning. And so, simple concept, she thought, if we could just give the patients what they prefer to do, we could even out the workload of our nursing staff. And so she asked me if I would be willing on my unit to try that experiment. I said, certainly. So we evened out the staffing between the day and the evening shift, and on admission, we would ask the patient, do you want to take your bath in the morning or in the evening? Sure enough, half of them wanted to take it in the evening, half of them wanted to take it in the morning. And yet, the nurses on the day shift simply could not leave their shift without completing all their baths. They felt their work was not done unless they had completed all their baths. And so we had day shift nurses frantically running around trying to do this when we were in fact staffed for half of that work to be done on the evening shift. And the evening shift would come on, and they couldn't do the baths because the baths were already done, and so they were overstaffed. So here's the lesson I learned from this experience. Just because everything is different doesn't mean anything has changed. As a unit, we were given the opportunity to provide service to these patients that could have been extraordinary. Extraordinary because we would have been honoring their bath preference rather than our routine. We were so ingrained in our routine that we could not see beyond that. There's a lot of rhetoric nowadays about patient-centered care. My contention is that without clear expectations of what that actually means, what we are doing is paying people to guess. Patient-centered care could lead us to extraordinary care, and not necessarily by spending more dollars. I know without question that regardless of the political climate, the organizational circumstances, or acts of nature, nurses will find a way to provide care. This was demonstrated to me quite poignantly on May 19, 2011. I'm part of the Sisters of Mercy health system. One of our hospitals is in Joplin, Missouri. And on May 19, 2011, that was a Sunday, it was an afternoon about 5 o'clock, an F5 tornado hit Joplin. Now, to give you a little picture, St. John's Hospital, our hospital, is on a hill, and across the street in a valley is Freeman Hospital, the other hospital in town. Our hospital took a direct hit. I think somewhat protected Freeman. They had a little damage, but nothing so severe that they could not continue to operate. I arrived there the next day, and I am not exaggerating when I tell you, you could literally see through every floor as you drove up to the hospital. The co-workers were able to evacuate 180 patients from that building successfully. We lost 5 patients in that tornado. And when I say evacuate, what I mean is they were able to carry 180 patients out of that wreckage and through a parking lot that had cars stacked 4 or 5 deep. To give you an idea of the veracity of this storm, there was a semi-truck in the parking lot. We assumed it was a semi-truck driver visiting a patient. What we found out a couple days later is that the semi-truck had been parked a mile and a half away at a truck stop and blew into our parking lot. That's how ferocious this storm was. What you need to understand is that around these two hospitals was a residential area, about 40 blocks around each hospital. And as our coworkers were taking patients out of that building, they could look out the window and see that all of those 40 blocks were completely gone. I am telling you, there wasn't a tree standing as high as me. And the houses were completely gone. And most of our coworkers lived in that residential area. So as they were doing this, they knew that their own homes and their own families were in jeopardy. And yet they evacuated those patients. And as they were doing that and getting to Freeman, of course they were realizing that many injuries from the tornado were arriving as well, and that Freeman was quickly going to be overwhelmed. And so a policeman happened to be driving by in his cruiser, and he shouted out the window at our coworkers, "The community center is still standing." And so as a group, they elected not to disperse and go find out about their own families, but to go as a group through 19 blocks of rubble to the community center, picking up medical supplies as they went, and I'm not kidding, and reestablish themselves at the community center. We were literally out of business for less than an hour. Now, what I want to say to you is that every single one of you in this room have coworkers who would do the exact same thing, because that's the kind of people that are attracted to healthcare. And so here's what I say. I tell this story frequently as I'm going across the country. And when I'm talking to leaders, my point in telling it is that they should expect no less passion and love from their leaders than what we have exhibited by our coworkers. And I believe that to be true. And that's why I can say, and seriously mean it, nurses will always find a way to care for their patients. That's not the point. But as leaders, it's our charge to make sure that in the way that they do that is stress-free and rewarding. So in summary, here's my plea to you. You're closest to the nursing process. Therefore, you are in the best position to make changes to it. Change or reform is absolutely necessary. Reform should not and cannot result in lower quality, and it is inevitable that we will experience higher volumes. Perhaps not in the same area. In other words, perhaps not in acute care. Because, of course, our length of stay is going down, and we're able to treat much more on an outpatient basis. But the sheer volume of work, the sheer volume of patients that we have to care for will indeed increase. Our processes and preferences should never override our patients' needs or desires, nor our physicians' comfort. And finally, I would say this: you have power over where you focus. That is a choice only you make. My plea to you is that you focus on ensuring that we continue to care for patients of this country with an ever-increasing high quality of nursing care in a cost-effective manner. I know you can do it because we're a group that throughout history has made that happen. Today is no different, and our charge has not changed. I thank you for the opportunity to talk with you today. You know, when I'm talking to students, I like to tell them, I'm often asked, how did you get where you are today? And I have two answers for that. The first is I volunteered for it. Now, that doesn't mean we were in a room like this, somebody came in and said, who wanted to be the CEO, and I raised my hand. What it means is that wherever I have worked, in every role that I have ever had, I have given my employer more than he paid me for. I look for jobs and I find a way to do them. And this is a message that I love to give students. And I use this example. My first job in my hometown, I was full-time in school and working evenings, and every day I would walk by the library, and the library was in disarray. Now, for those young people in the room, of course, we used to have paper libraries that clinicians had to use to research what to do with their patients. It was just in terrible shape. So I went in one day to the administrator and I said, would you like me to straighten out the library? And he said, well, you know, we used to have a librarian, but we had some budget cuts and we had to eliminate that position, and I really don't have any money to pay you to straighten out the library. And I said, I didn't ask you if you wanted to pay me to straighten out the library. I asked you if you'd like the library straightened out. Of course, he was shocked and said, sure. And so for the 3 years that I worked at that hospital, I would go in between classes and I would straighten out the library. And then one day, we were having a meeting of the nurses, and this new thing was being talked about. This tells you how old Di Smalley is, talking about successful aging. This new thing was CPR. And we were having a debate about whether or not one of us should bother to learn it, just in case, just in case we ever really wanted to use it on a real patient. And so I volunteered to go learn CPR and teach the rest of the nurses how to do that. And that, of course, was not a paid thing that I did at the time. But I'll tell you this, and this is what I say to students. I'd been there about a year. I was 23 years old, and a weekend supervisor position came open. And the older nurses didn't want the weekends and didn't want that position. So they knew they'd have to hire a younger nurse to do it. And which one do you suppose they looked at? Now, I'm not saying volunteer for self-serving reasons. What I'm saying is it gives you a feeling of investment in what you do. And as a practitioner who loves and has a passion for what they do, I think you should always volunteer more than what your employer pays you for. And the other thing I say to students is this. For 40 plus years, I woke up every morning and I've said to myself, thank God I get to go to work today, because that's how much I love what I do. And if you're not in a role where you can do that, then I think you should continue to search till you are. So my prayer for each of you is this. I hope that each of you wake up every morning and say, thank God I get to go to work today. Thank you. So I'm told, thank you. I'm told I have time for questions. So I have a few questions.
Hi, I'm Susan Shapiro from Emory University and Emory Healthcare in Atlanta, Georgia. Thank you very much for that really interesting talk. I'm wondering, I listened to you speak both about primary care and patient panel size and acute care and the need to keep our physician colleagues informed. And I'm wondering how you have experienced interprofessional collaborative practice as a method, first of all, to flatten the hierarchy for patient care, secondly, to put patients at the center of everything we do, and how that has impacted the value proposition in your organization.
Sure. Happy to answer that. I like to consider our organization, by the way, just to give you a little background, it's 17 hospitals, 68 clinics across the state of Oklahoma. And we pride ourselves on being physician-led and professionally managed. And that isn't just something we say, it's something we mean. So that in every committee that I have, every executive leadership team meeting, whatever, there's as many physicians as there are other operations folks. We do the same thing with the other clinical aspects as well, because it's important that everyone has a voice in how we do things. And we're very much into trying to change the way we practice so that we actually can, in fact, change from 3,000 active patients to 10,000 in the case of primary care physicians. So we're experimenting with things like the medical home model, patient population therapy and group meetings for chronic diseases. We're looking at ways that we can change how we do things, and we're relying more on the post-acute service line than we ever have in the past, making sure that we get patients in and out. Care management, it's hard for me to go through all this in a short time, but care management plays a big part in making sure that that happens. So we're very much aware of the need to change. We're certainly not there, but I think the biggest first step is making sure that clinicians have the equal voice at the table to other forms of management. Be my answer. Another question?
Yes. Pat Hinton Walker, Uniformed Services University in Maryland. I wonder if you could just, for example, I understand you're physician-led and in terms of your organization, but you were talking about the nursing process. So my question really is a follow-up of the previous one, and that is that perhaps where we are now in the work that we're doing in interprofessional health education, that perhaps there is a process that's not either a physician process or a nurse process, but a process that we might all use together. So it's not just about collaboration on the back end of it.
Right.
But I would be interested in your perspective outside your own organization about how we might think about that differently in this day and time. Second of all, when you were making the point about not enough providers, I wonder what your perspective is about the value proposition of having APRNs in a variety of different roles that can meet that need in a variety of different places, not just in the traditional healthcare community.
Good. Very good point. And I meant to cover that and I didn't, so I will. So the first part of the answer is that I'm a strong believer, as you could tell from what I said, in performance improvement. Another outlook of that one might be Six Sigma, would be a big example of that. We're very big on Six Sigma in our organization and use lean methodology and Six Sigma a lot to look at and analyze processes. It's just one tool. There's a number of them out there. But I think that sometimes if we can take the emotion out of what we are doing and look at it step by step, it's easier to see where the efficiency in those steps might be able to be captured, and what is value added and what is not value added in a process. So any tool like that, I think, helps you look at that. And in answer to your second question, no question there's a role for nurse practitioners and physician assistants in healthcare. I think an increasing role. And we are experimenting in a number of ways as to how we might enhance and increase that role in our own organization. An example of that would be this. We have right now what we call a rapid referral team. And when I came to Mercy, the big hospital, our flagship hospital in Oklahoma City, was accepting about 6 patient transfers in a month. The reason the number, and it's a huge medical center, 700 plus beds, the reason it was only taking that number was because there wasn't physicians who would accept them, and it was too hard for other hospitals to get through our system to get to the admission and so forth. And so we started a rapid referral team, which is nurse practitioners 24/7 around the clock. And all of the hospitals in Oklahoma know that they can make one call to this nurse practitioner. The answer is always yes. And then the nurse practitioner evaluates and works out what specialists we need to be involved in the care and so forth. So we've gone from an average of 6 referrals a month to an average of 160 per month. And this hospital is the only one that I know of that's had double-digit growth over the last 3 years. So I think there's unusual roles like that we need to think of the expertise that a nurse practitioner brings to the table that others don't have and are able to accomplish that. So big, strong role. Of course, we're using them in primary care physicians' offices as well and trying our best to sort out how best that looks. I experimented over the last 3 years with retail clinics staffed by nurse practitioners. Did not find that particularly successful, mainly because it was not rewarding for the nurse practitioners. The work was just too limited in scope. So we're still fussing with that, but good point. Glad you made it. Yes.
Thank you. Trish Seifert, I work in a cardiovascular operating room, and we have talked about the strategic plan, cost effectiveness, you've alluded to finances and whatnot, and I wonder if there isn't a role for greater emphasis on our education of nurses about financial resources, because so much of it is driven by that, and I think that's kind of a weakness in our knowledge base.
Absolutely. I think you're absolutely right. Part of what I learned when I took a hospital out of receivership was this. The more transparent you are, the more understanding everyone in the organization has about the finances of the organization, the better chance you're going to have of getting yourself to a financially sound point of view. And the surgical department is one of those areas that's critical in doing that. I founded a company in Omaha that's actually a wholly owned subsidiary of Allegiant called Avantis, and what we do is workforce strategies for the healthcare industry. And so I spent a good 3 years running around the countryside consulting with organizations, and invariably what I would find is that in the surgery department there would be things that could be significantly and dramatically done to change the bottom line of hospitals. And so you are absolutely right. And what I would suggest is that if you're not right now being able to be privy to that kind of information, you need to force the issue. And the more you know about the finances of the organization, the more easy it's going to be for you to help the organization stay afloat.
Over here?
I'm sorry.
Hi.
The light's blinding me.
I
I'm sorry, I
gotcha.
didn't see
no
you there.
problem.
Sorry.
I'm Beverly Malone with the National League for Nursing, and I am amazed by your career and in awe of where you're standing as a nurse. So pleased that you're saying, I am a nurse and I've accomplished all this. So, right on.
Thank you.
But at the same time, I do have an area of difference with you.
Sure. And that's what makes the conversation rich.
I'm so glad to be
That's
necessary.
Right. That's right.
I don't agree with you that the physician has to always be the head of the patient care team.
Oh, yeah. No, I don't either.
Yeah. And I just want to get, because
Yeah.
I disagree with someone's at that point in their career, I want to give you a little bit of background as to one of the reasons that I disagree. I was lucky enough and fortunate enough to be part of a team of nurse leaders who met with physicians for an extended period of time to discuss this issue about captain of the ship. And in this day, in this time, with the Future of Nursing report by Robert Wood Johnson and IOM, and we came to the conclusion that there doesn't need to be a captain of the ship, that what we need is situational leadership if we're really patient care centered.
Right.
So when it's appropriate for the physician to be the head of the team, go for it. When it's appropriate for the pharmacist to be
Sure.
the head of the team, go for it. When it's
Sure.
appropriate for nursing to be the head, that's what we came to. And we wrote a wonderful paper about that to tell the world, to say, look, we've got to readjust this whole idea. And then our colleagues at the American Medical Association found out about it and they kiboshed it. So when I hear a nurse saying that the physician has to always be the head of the team, it gives me heart palpitations.
Yeah, I hope that's not what I said. What I thought what I said was this, that when the physician is the head of the team, that's what should
I
happen.
love the rephrasing, and I'm fine with that. And
Yeah.
for me,
Yeah.
I'm okay as long as when
Right.
he or she
Yeah.
is the head of
Yeah.
the team. If you could just add, and when nurses are the
Sure.
head of the team, that would
Yeah.
really punch it for me.
Yeah, okay. In fact, in case you haven't noticed, I am the head of my team. So, there you go. Yeah. Okay, over here.
I'm Inga Corliss from the MGH Institute of Health Professions, and I want to continue on with what Dr. Malone has said. Hospice care, what? I'm sorry. I want to continue with what Dr. Malone has said. I also heard MDs as leaders of the team. I heard physicians and their patients. I heard physicians' comfort. There was a great deal of focus on physicians when otherwise you always mentioned the team. Hospice care has provided a wonderful example of teamwork, and it varied according to what the issue was, what the needs of the patient is and was. I think it's a good model for all of us. Given your enthusiasm, your creativity, I think it's important for you to be sensitive to these issues. We have this audience is filled with creative, wonderful leaders in nursing. I think we were all concerned about what you said.
Thank you. Thank you. Appreciate the feedback, and of course I agree with everything you said. Thank you.
I want to thank you so much, Di. Excellent comments and very thought-provoking. And I do sense from the comments that you shared in return that we do have similar views, but maybe the wording and how we have to frame it. Beverly, your points are great. Wonderful closing session, and I really appreciate it. Thank you so much. And I see Diana already, ongoing conversation and communication. So I'm going to just make a few comments, and then we're going to be closing. And we'll have healthy interludes by yourselves as you leave the room. But I have some announcements, and I'm going to just make a few comments, and then I'll make my announcements, and then we'll bring closure. But I was going to make a kind of a lengthy, not too lengthy, but a lengthier review. But you know, we had such a good morning, and the discussions about the issues that interest you, and the realization and the emphasis that I'll give you my 4 points instead of my talk. And the 4 points were that this is nursing's time. And the idea, when you look at what's happening out in the world, the partners that are coming to nursing, the use that we're seeing of nurses being able to be helpful in a full range of roles and settings, the emergence, the slow, steady movement of the APRNs around the country. The American Medical Association is not pleased, but there's steady progress being made. And what we want at the end of the day is partnerships. So I am so heartened by what I'm seeing. So this is nursing's time. The second thing is that things are changing. And there are so many indicators, and I had a raft of these, but just stop and think what you're reading, what you're seeing, the hopeful signs. We've got new funders coming on board to say, I want to support, like at the University of Pennsylvania, the creation of 100 new PhD-prepared nurses by the Robert Wood Johnson, giving $20 million. And at our school, the University of Minnesota, a foundation that most of you have never heard of, the Benson Foundation, stepping forward and giving $10 million to help support the preparation of 500 DNP prepared nurses. So groups that we have not, thank you, we're thrilled, but groups that are not the traditional are stepping forward and saying, I want to support the work, and we're going to see more of that. So this is nursing's time. Things are changing. We still have a lot of problems out there that need our concerted effort. And the effort of people, nurses working together, and then we nurses working with our physician colleagues, consumers, other advocacy groups. So there are a lot of issues, things that are not moving forward in the legislative arena as we would hope they would, things that we have to make sure don't get repealed, provisions that are already in the law that if they get repealed will stifle not only nursing opportunities, but the access of the public to some of the sources and resources that they want to have through nurse practitioners. So we have a lot of problems and a lot of work. And then the academy. I said this morning, we are not poised. We are moving ahead. And so we are equipped. We've got a wonderful leadership team taking us forward. So lots going on. The academy is going to be a vibrant leader in that whole initiative. And then I want to conclude with a challenge to each of us, extending what Diana said earlier, that there is a role, whether it be time, talent, treasure, or some combination of the three, that each of us needs to play. And so whether it be contributing to the Ruby de Tournier, actively engaged in a committee or a task force, sending your ideas in, voting, finding sponsors for next year's conference, stepping forward to say, I know a funder that would love to do some work on health disparities. So think of all the different ways that you could really help us move the work forward. So finally, this is nursing's time. I look forward to joining you in a new role, sitting at the front here in the room, speaking up and making contributions of all kinds to the academy, and joining you as we move forward to make healthcare better and health for all that we serve. So in conclusion, it's been an honor to be your president. And I do have a few announcements, which I will share with you, and then we will be adjourned from this morning, and I encourage you to go out and do your own particular form of healthy lunch and healthy interludes. So let me share some of the announcements. First, remember for all new fellows to meet in the lobby by the escalators by 5, but certainly 5:15 sharp. The picture is going to be taken at 5:15. And you will want to be in this picture. And you can imagine it takes a little time to organize 172 people. We also will have some meetings this morning at lunch. The new board will be meeting in the Olympic Room at 12:15, and there will be lunch available. The past presidents will have a luncheon as well in room 989 of the hotel. The rest of you are encouraged to enjoy this afternoon. There are many sessions and meetings and expert panels, so our work is not done yet, but be sure to get ready for this evening. It will be a wonderful celebration of our 40th anniversary. And so with that, thank you all for coming to this conference, for being so engaged at the forum and this session, and enjoy the rest of the day. Thank you.